Hello, my name is Jaspreet and I'm a master's second year student. Today we'll be talking about complex wound dressings. So previously we have discussed um, simple wound dressing and I hope you guys had a chance to practice the some of the simple dressing that will make it easier for you to understand the complex wound dressing. So, the outcome for today's lecture would be by the end of the presentation, we should be able to identify the patients at risk for development of a pressure ulcers or wound complications and determine preventive measures to promote skin integrity and to treat wound problems once they have developed. Before we start, I would like you to pause video and think about the asepsis principles that we have discussed in simple dressing lecture. I will talk about inflammatory process in the next slide again. And we have also discussed the types of wound healing, that is primary, secondary, or the tertiary intention. And the phases of a wound is hemostasis, inflammatory, proliferative, and maturation phase during the lab lectures. And we will quickly go over the conditions which may affect the wound healing. Specifically the type of the wound, presence of infection, age of a patient, what's the hydration level, and presence of any chronic disease, for example, diabetes, poor circulation to the wound area, repeated trauma, or a patient's lifestyle, like patient drinking habits, smoking habits, or eating habits. Next, we'll talk about what is the difference between inflammation versus infection, because throughout the lecture we'll be talking and referring to these terms. Inflammation process is the second stage of the wound healing and begins right after the injury when the injured blood vessels leak transudate, which is made of usually water, protein, salt, which causes a localized swelling. And the inflammation both controls bleeding and prevents infection. The fluid engorgement allows healing and repair cells to move to the site of the wound. During the inflammation phase, damaged cells, pathogens, and bacteria are removed from the wound area. The white blood cells, growth factors, nutrients, and enzymes create the swelling, heat, pain, and redness, which is commonly seen in this stage of the wound healing. Whereas the infection, it is not an expected phase of wound healing. It occurs when germs such as bacteria or other types of germs, pathogens grow within the damaged skin of a wound. Symptoms could be like an increasing pain, swelling, redness around the wound, foul odor, purulent drainage. In severe cases, if left untreated, the infection may become systemic and it may cause nausea, chills, or a fever. So, okay, now let's talk about how does a failure of a wound healing looks like. So, first of all, there could be a presence of infection that we have already talked about. And you must remember from Nurse 224 that dehiscence. So if you can see on this picture, there is a separation of the incision. So dehiscence is a partial or total separation of a previously approximated wound edges due to failure of a proper wound healing. This scenario typically occurs 5 to 8 days following surgery when healing is still in the early stages. The causes of dehiscence are similar to the causes of a poor wound healing and include ischemia, infection, increased abdominal pressure, diabetes, malnutrition, smoking, and obesity. The superficial dehiscence is when the wound edges begin to separate and by increased bleeding or drainage at the site. So it is only the separation of epidermis or the dermis that's called superficial. We should assess the wound for worrisome signs, including presence of infection or necrosis. Prompt identification is important for prevention and worsening of dehiscence, infection, and other complications. And the third one is evisceration that has also been covered in 224. So if you look at the picture, it is the protrusion of internal organs, and it is usually abdominal. It doesn't have to be abdominal, but it's a separation of the subcutaneous and the internal organs come out of the incision. It is a rare but a severe surgical complication, and it is emergency and should be treated immediately. Next is we'll talk about complex and chronic wounds and what are the difference between two. So complex wounds are hard to heal wounds, and it may present as an open sore or injury that isn't healing within the expected time frame, and also that exposes muscle or bone, sores on the lower legs. And a chronic wound is one that has failed to progress through the phases of healing in an orderly and timely fashion and has shown no significant progress toward healing in 30 days. Factors contributing to the chronicity of the wound may include pressure, trauma, or lower extremity wounds, increased bacterial load, degraded cell surface structures, or inappropriate treatment. Chronic wounds are typically identified by a raised, hyperproliferative, yet non-advancing wound margins. The area around the wound will be inflamed, and this inflammation may negatively affect healing. The complex wound could be acute or chronic, but chronic wounds are always complex because multiple factors contribute to the chronicity of the wound. So, now is the important terms. There are, like, before we discuss further, we need to understand a few wound terms, as it will help to better understand wound healing and also help you understand or describe the wound when you're going to do documentation. First is the pink. This one is not really a pink. It's more like a heal. It looks like a healed wound. But you can see a little bit of pinkish color at the wound bed. So light pink in color represents epithelial tissue, usually migrates inwards from the wound margins, or may appear as a small island of a tissue over the surface of the wound. And next is the red. It's a healthy granulation tissue, and it's bright red with a grainy appearance due to the budding or the growth of new blood vessels into the tissue. This tissue is firm to touch and has a shiny appearance. It is essential to protect the granulation tissue to allow the epithelialization process to proceed in order to close the wound. And the next is the yellow and a green. So this is also a necrotic tissue and is a non-viable fibrous yellow tissue, which may be pale, as you can see in this, and you can see slight greenish color that have washed over the wound. So it formed as a result of infection or the presence of a damage in the tissue. And the next one is the black. So black is called a necrotic tissue and also termed as an eschar. Is easily identified as a black or dark brown in color. It could be dry or moist and present as a thick and sometimes leathery necrotic tissue. It cast off from the surface of the wound. This eschar inhibits the proliferation and maturation phase of the wound healing by preventing the formation of granulation tissue and inhibiting wound contraction and epithelialization. So moist eschar supports growth, bacterial growth, increasing the risk of infection, and ideally should be debrided. Now let's talk about types of ulcers. There are two types of ulcers: pressure ulcers and leg ulcers. So pressure ulcers also known as a bed sores, are the injuries to the skin and underlying tissue, primarily caused by prolonged pressure on the skin. They can happen to anyone, but usually affect people confined to bed or who sit in a chair or a wheelchair for a long period of time. Therefore, make sure you turn your patients who are immobile or bedridden every 2 hours. So next is the leg ulcers. There are further few different types of the leg ulcers. First are arterial. Arterial wounds are also known as arterial ulcers, and these are the painful injuries in your skin caused by poor circulation. These typically happen when blood is unable to flow uh, into the lower extremities like the legs and the feet. When the skin and underlying tissue are deprived of oxygen, the tissue starts to die off and form an open wound. Next is the venous. These are the leg ulcers caused by the problem with blood flow in the leg veins. Normally, when you get a cut or scrape, your body's healing process starts working and it closes the wound. But ulcers may not heal without a proper treatment. The difference between arterial ulcers and venous ulcers is that arterial ulcers develop as a result of a damage to the arteries and due to the lack of blood flow to the tissue, whereas venous ulcers develop from the damage to the veins caused by an insufficient return of the blood. Unlike other ulcers, these leg wounds can take months to heal if they heal at all. And there's a mixed ulcers as well. So people with these ulcers have a venous disease and a significant level of arterial disease as well. But their arterial blood supply is not yet poor enough to cause critical ischemia. The key clinical factor in mixed etiology ulceration is that without intervention, arterial disease is progressive and eventually the arterial problem will take precedence over the venous problem in treatment decisions. Last is the diabetic or the neuropathy. So diabetic ulcers are the open wounds or sores usually found on the feet. So over time, high blood sugar levels in diabetic patients can damage nerves and blood vessels. And there is a less blood flow, especially to the hands and feet, which make it harder for sores and cuts to heal. It make you more prone to get an infection too. So what's more likely is that diabetes is linked to a condition called peripheral artery disease, which lessens blood flow to your legs and feet. Let's talk about what are the prominent pressure points while standing, sitting, or a sideline position of the immobile patients. So if you can see here, while you're lying in a supine position, the first thing is this occipital region. It touches the bed. So pressure ulcers usually form on the places where you have a maximum pressure, usually bony prominences. And you can see scapula, spinous process, iliac crest, sacrum, ischium, and Achilles tendon and heel. So, and while you're sideline position, there is an ear, acromion process in the shoulder, interior iliac spine, trochanter, thigh, medial knee, and lateral and medial knee, and lower leg, medial malleus and lateral malleus, and the lateral edge of the foot. While sitting, so you are continuously touching your scapula to the wheelchair, and then there is a sacrum, ischium, posterior knee, and the sole of the foot. These are the common pressure ulcer sites. So this is why you need to turn your patients every 2 hours to take the pressure off from these bony prominences. Next, let's talk about the risk factors for the pressure ulcers. So there are multiple risk factors that include, first is the immobility. So if the patient is unable to mobile due to poor health, spinal cord injuries, or any other reasons that causes the patient to stay in a bed, that increases the pressure. Next is the incontinence. The skin becomes more vulnerable with extended exposure to urine and a stool, so that excessive moisture can cause the pressure ulcers. And next is the lack of a sensory perception due to the spinal cord injury or other neurological disorders, or we discussed previously diabetic neuropathy. Can result in a loss of sensation, and an inability to feel pain or discomfort can result in not being aware of warning signs and need to change your position. So patient can stay in that position for a prolonged period and will not realize, oh, I'm hurting, there's too much pressure, so it can develop pressure ulcer. And there's a poor nutrition and hydration levels. People need enough fluid, calories, proteins, vitamins, mineral in their daily diet to maintain the healthy skin and to prevent the breakdown of a tissue. So with a poor hydration, if there's too much dry skin, that can cause some friction, shear that could be responsible for the pressure ulcers. Then there are some medical conditions too. We talked about the patient with the diabetes, arterial disease, or the vascular disease, which decreases the blood flow, and at the end, there's an increased risk of tissue damage, such as bed sores. So there are some psychosocial factors as well. If the patient is living in, suppose there is a diabetic patient, it's living in a poor house condition, or he doesn't have proper shoes, and he might end up having a foot sore that will develop into an ulcer as well. Next is we're going to talk about staging the ulcers. So staging ulcers provide a baseline situation against which a patient's plan of a care can be evaluated. They can range from mild reddening of the skin to the severely damaged tissue, and sometimes infection that extends into muscle and bone. Pressure injuries are usually divided into the 4 stages. Stage 1. So stage 1, the sores are not open wounds. The skin may be painful, but it has no breaks or tear. If you can see here, this is the sacral area where, or you could say coccyx area, where there's continuous pressure. There's a redness on the skin. So these can range from mild reddening to the severe damage. And pressure injuries are in a dark person. The area may appear to be different color than the surrounding skin, but it may not look red. So if you touch, the skin temperature is often warmer, and it can feel firmer or softer than the surrounding area. Next is the stage 2. So at the stage 2, the skin breaks open, wears away, or form an ulcer, which is usually tender and painful. The sore expands into deeper layers of the skin. It can look like a scrape, abrasion, blister, or a shallow crater in the skin. Sometimes this stage looks like a blister filled with a clear fluid at the stage. Some skin may be damaged beyond repair or a dye. So if you see a patient in the clinical area and he or she has developed a blister, then you will consider it stage 2 pressure ulcer. Not everywhere, but if it is related to the pressure sore. So next is the stage 3. In the stage 3, the sore gets worse and extends into the tissue beneath the skin, forming a small crater, and fat may show in the sore, but not muscle, tendon, or bone would show on this stage. Next is the stage 4. The pressure injury is very deep, reaching into the muscle and bone and causing extensive damage. The damage to the deeper tissues, tendons, and joints may occur. So if you look in this picture, it looks very similar to stage 3, but the only difference is this white portion is the exposure to the bone. If there's a presence of any tendons, bony prominences, it means you will consider as a stage 4. And the depth of this may vary. There might be presence of undermining and a tunneling in this stage. And the next one is the stage 4. So these are the unstageable stage. It means the stage isn't clear because under the scar you cannot see what is happening to the tissue. The base of the source is covered with a thick layer of the tissue, and there may be pus coming. It could be yellow, gray, green, brown, anything. So we cannot see the base of the sore to determine the stage. Next, as you could see, this previous wound, starting from the stage 4 and 5, the wounds are not looking good and are difficult to heal. So to avoid these from happening, first of all, prevention is the key. But if these things, how you can prevent this so that these things don't happen? We always know in the nursing process, assessment is the first thing. So we will use a Braden scale. You have been into the clinic and you must all be familiar with this right now. So to assess the skin, we assess the risk of developing a pressure ulcer. We use a Braden scale in the clinical. And next is we will assess the skin, inspect the skin daily, look closely at skin for warning signs of a pressure ulcers. Most commonly, the people with the darkest skin complexion, there are chances that those signs get missed. So it is important to recognize the signs of the skin breakdown in those patients. And next is to keep skin clean and dry. Wash the skin with a gentle cleanser and pat dry. Do not use those hard towels that you'll find in the hospital and just start like aggressively wiping patients. Do this cleansing routinely, regularly, to limit the skin's exposure to the moisture, urine, and stool. Do not leave your patients in the urine or stool. So before you finish your shift, it is important you check if your patient has incontinence, to check if it needs to be changed. Next is protect the skin. So use moisture barrier creams to protect the skin from urine and stool. Change beddings and clothing frequently if needed. Watch for buttons on the clothing and wrinkles in the beddings that irritate the skin. And relieve pressure. So beside repositioning, we need to reposition bedridden patients every 2 hours. We also use cushions or special mattresses to relieve pressure and help ensure the body is well positioned. Do not use donut cushions as they can focus pressure on the surrounding tissue that can worsen the condition. If the bed can be elevated at the head, so do not raise it not more than 30 degrees unless, as we discussed in a previous lecture, patient is getting NG2, we need to keep the pressure bed of the head greater than 30 degrees. So you can use alternative methods to decrease the pressure, to relieve the pressure from the sacral area. So this helps prevent shearing as well. And next, we have to address the patient factors. If the patient has a diabetes, so diabetic control, nutrition, make sure the patient is getting enough protein and hydration to keep the skin hydrated, and use of a proper dressing. So use of a cotton-based sheets. You have all probably noticed in the clinical area, there's those white cotton-based sheets, and try to avoid wrinkles. Your patients must have asked you, hey, I can feel a wrinkle underneath, because they're aware the wrinkle can cause pressure injury. So this is a Braden scale I was talking about. You probably all have seen in the clinical area. There are a few factors that we have been discussing. First is the sensory perception. Can patient feel if the pressure is there? Can patient move their legs? So based on that, it ranges from 1 to 4. Then there's some moisture. Is patient incontinent? How frequently incontinence is? And next is an activity level. Patient can move or it's a bedridden. Next is the mobility. Can patient activity and mobility are slightly different, but you have to understand the mobility means patient can major frequent changes in the body. So if they're turning while they're lying down, can they turn from right sideline position to the left sideline position? So it means the patient does not have any limitations moving in a bed. Next is the nutrition, how the patient is taking meals. Are they taking enough protein or not? So then there's a friction and shear. So these will purely assess that if the patient, we regularly need to boost the patient, there are chances that patient will have risk of developing pressure ulcer from a friction or a shear. So in the clinicals, you will notice there is a set. If the score is between the maximum score for the Braden scale is 23, and if it's more than 18, it's between 18 and 23, there's a less risk of pressure sore, and if it's between 14 to 18, then there's a moderate risk. If it's less than 14, there's a high risk. So my numbers could be a couple off, but please, when you go next time, check in the clinical area. And that is end of the video. Thank you.